so hi all, thank you so much for being here. I wish we had a little bit more people, but last day, so forgive. Okay, so first this is a session on pigment and darker skin. I think we begin with none other than Dr. Anil Ganju. He's one of the most renowned specialists coming from India. And Dr. Ganju will be speaking on 660 nanometer Ruby Touch, which is a safer alternative for epidermal lesions and darker skin.
Okay, thank you, Dr. Atula, and thank you, whoever is here, for this session. So this session is about particularly skins of color. Of color are different. They react to, photo devices differently than the Caucasian skins, and we now know that we have to be a little different while we are treating skins of color to get good results and less, side effects. Okay. The journey of Q-switch lasers has been long, and there has been a lot of evolution since we started. Way back, they were just devices to treat tattoos only, and a few pigmented lesions. But over the past few years, maybe a decade or so, the applicability of the Q-switch lasers has really widened, and we use them as primary lasers now. Earlier, the laser reduction was the first laser to acquire, and now we look at Q-switch lasers as one of the first lasers to be acquired when we go into laser practice. And lots of changes, like tattoos are treated in lesser number of sessions now than they were treated earlier. And by modifying the pulse width, so we can modify the pulse width from the pico to the nano to the micro to the milli. So we have so many types of pulse widths, and their applicability is different. You can treat pigmented lesions, you can treat scars, you can heat the water and cause textural improvement, and so on and so forth. And then another new thing that has happened is the addition of the die kit hand pieces to these newer machines. So what are these die kit hand pieces? They contain a special die, and that die has the ability of converting the laser light, be it 1064 or 532, into a newer wavelength, although the basic laser characteristics are lost when this is done to the laser light. So we have two types of die kit hand pieces: the 595 nanometer die kit hand piece, which converts the laser light into a 595 nanometer, which becomes vascular specific. So superficial vascular aberrations like telangiectasias, rosacea, erythema of acne, all that can be taken care of by this. And we have another one, the Ruby Touch die kit hand piece, which produces a 660 nanometer wavelength. The 660 nanometer wavelength again is used for epidermal pigmented lesions. Why do we use this instead of what we had earlier? We had 532, good enough. But the problem with 532 is that it is associated with more side effects. Why? I'll tell you as we move on. So as I told you, we do a lot of new things with our new Q-switch laser machine. We do laser toning, we do R0, R20, we use the quasi-long microsecond pulse width, 300 microsecond pulse width for heating the skin to improve texture, etc. We do carbon peels, we remove different colored tattoos, we have the pico, we have the PTP mode, and so on and so forth. Therefore, all these new things have really helped us use this machine in so many different situations. And now coming down to 660 nanometer wavelength. The problem with 532 nanometer is, one, it is a very high energy pulse width, absorbed more into the melanin than the 660 or a 694 Ruby laser, because the melanin is more absorbed at absorbs a shorter wavelength better than the longer wavelength. So if you go back to your basic laser physics and look at the absorption spectra diagram of various chromophores, the melanin is absorbed maximum at around maybe 500, and then it goes down. 1064 is absorbed very, very less by the melanin. So 532, one has a problem of excessive absorption into the melanin, producing excessive heat, leading to more collateral damage and their side effects. The other thing that the 532 is capable of doing is getting absorbed into the vessels around also. So 532 is nearer to the peak absorption spectrum of oxyhemoglobin and hemoglobin, which is about 577 nanometers. So 532 not only gets absorbed into the melanin, it also goes into the oxyhemoglobin. Therefore, there is more liberation of heat, more collateral damage, and likelihood of greater side effects. This makes the 660 nanometer Ruby touch, as it's called, Ruby touch because it's ruby-like, variable YAG touch it is called. So it is ruby-like wavelength. This becomes safer than the 532. So look at this video. It will tell you how 532 is different than 660. 532, as I told you, is nearer the maximum absorption spectrum of the oxyhemoglobin, so absorbed into this. So here we have hardly any vascular absorption. That's very important. So more heat generated here, lesser heat generated here. So as we move on, say for example, we treat it with 532, we break down the pigment, but at the same time, the vessels are also targeted. More heat, okay, you have treated, then you go to 660. You will specifically treat only the pigment. As I told you, there's hardly any absorption into the vessels at this wavelength. Okay, so we've done the treatment on two sides with the two wavelengths. We go on, day 3, day 5, day 6, most of them start clearing on both the sides. But because you have produced a lot of heat on the 532 side, there'll be more erythema, lasting erythema, and then more likelihood of PIH. So these are some company photographs that show that more purpura happened at 532, less purpura happened at 660, and finally the 660 was associated with lesser, side effects. So these are the usual tips. You have to be very careful while you are doing this because, this is also a shorter wavelength and the likelihood of getting absorbed into the melanin is high, into the epidermal melanin is high. So therefore, be careful. Make sure that you are vertical. Make sure that your fluences are not high. Do not produce too much of frosting. Petechiae, not at all. Be very, gentle. Decrease the fluence if there is too much of frosting. And gradually increase the fluence to get a little bit of frosting and erythema, and that's your end point. Don't go to too much of frosting, too much of petechiae, etc. And after the treatment, the usual tips: not to touch, not to scratch, etc. Avoid exercising immediately. You can give some little bit of dressing also to prevent infection. And we've been doing 660 for many of our patients. Earlier, we were doing 532. Some of them used to get hypo or hyperpigmented pigmentation post-op. But 660 has been helping us, give better results in superficial epidermal lesions like freckles, lentigenes, and cafe au lait macules. So efficacy is equal, but PIH is less. So these are the new machines that have come, and these are the die kit handpieces. This is the gold, and this is the Ruby Touch, and this is what I am talking about. And these are some of the results with 660. You can see good clearance, and most of these patients have not seen, side effects happening. So therefore, although both 660 and 532 can be useful in superficial epidermal lesions like pigmented lesions like freckles and lentigenes, 660 has an advantage because I told you 532 has the problem of being very high energy, more absorbed into the pigment and causing a little bit of absorption into the vascular component and therefore causing a lot of heat, etc. So more side effects. So 660 seems to be a good option in patients of freckles and lentigenes, giving a lesser side effects. So this was a shot in Safari World in your Bangkok only in 2019. So I had attended, that was not IMCAS, that I had come for some other meeting. And yesterday, coincidentally, I went to the Safari World and lost my wallet. But I got it in the morning, the lost and found. No, passport was with me. Rest of the wallet. And the lost and found guys have called me in the morning. I got it. They're sending it across. So thank you very much for your kind attention. And we move on now. Can you open this up, please? Okay, let me introduce Dr. Atula. Dr. Atula is into a lot of scar management, particularly she has done a lot of work into the microneedle radiofrequency. It's really impressive the way she has been showing results in her patients. Today she talks about Q-switched lasers in pigmented lesions in skins of color. So as I told you, skins of color are different. So over to you, Atula.
So thank you very much, sir. And I'll be very quick about this. Q-switch lasers, nano or pico, both work in pigmentary conditions. I want to show you my experience with nano and what you can do with a simple device, basically with pigment. Nevus works very well. Dr. Anil already discussed this. This is a speckle nevus, as you can see. Treated with 1064 nanometer, deep wavelengths, spot size 4 to 5, energy 0.4 to 0.56 weekly. Your endpoint is important when you're using dark skin. Mild frosting, erythema, and edema. This is what I did, and I want to show you this is after the second session. That was baseline. Second, third, improving, 5. So baseline, 5 sessions, complete clearance, 1064 nanometer, deeper wavelength used. Another nevus, again, single pulse, 1064, darker skin, like Dr. Anil said, very safe with 1064. I do the 532. I don't have the device that he has, but we can see a good result with this. Again, mild frosting is your endpoint. 5 sessions. Other side of the same patient, 5 sessions, same patient. Another nevus in that area, like I pointed out, 4 sessions, same. Let's come to melasma. Do we use the Q-switched or do we not? That is the most important question. Melasma is an inflammatory disease, never goes away. Never goes away. Q-switch lasers in dark skin always darken it up and it rebounds back. Understand this. Use it on laser toning mode. 1064, energy very conservative, large spot size. I always use 8 or 9. Endpoint, very mild erythema, interval 6 weekly. I think we know this. But I want to show you this case because this was when I started practicing with melasma with my Q-switched. This is masked with steroid use, right? You see some redness, you see inflammation. This is not naive. This is not a naive melasma. What I did was I did topical tranexamic acid, topical vitamin C alternating at night. I did the laser toning mode with Q-switch, and I immediately follow it up with a mild peel, like a lactic acid peel. This is what I did. This is baseline and post 3 sessions. Lot of sunscreen, mind you, but no oral tranexamic acid here. So you have to use a lot of combinations, and I'll show you. This is the other side of the same patient. Melasma, again, this patient was on oral tranexamic acid. You can obviously combine. And this is the nose of the same patient. And here, like I said, I didn't do a 250 BD, which is the standard. I did a 250 milligram OD. I did a 1064 nanometer laser toning plus a lactic acid peel in the same sessions. This is over many sessions. This is over many, many sessions. Difficult melasma, again, treated in the same way. Topicals like hydroquinone. I never give a triple combination. No steroid in my practice at all. Topical hydroquinone, sometimes topical retinoid, cyclical therapy. Again, melasma improving, not going, just improving a little bit with mild laser toning. Other side of the same patient. I want to show you this because this is a patient with scars, and he also had some PIH and some melasma. I did HQ 2%, hydroquinone, twice a week at night. I did tretinoin a little bit for the scars and for the remodeling effect. 0.025% twice a week at night, short contact, not leave it overnight, and I did the same Q-switch NDAG laser with LAP. You always have to be very careful, space it wide apart. 8 weeks. Sometimes I really do it 8 weeks at an 8 weeks interval. This is again a little melasma. Let's come to laser toning. This is same. You can see the t-shirt color is the same. This is after the same session, just brightening. Laser toning helps to brighten, improves the pores. Just the appearance looks better here. This is again, this is different sessions, but I would like to show you the cheek area of this patient. Again, improvement in the pore size. Laser toning is something which we do a lot. People come to us for rejuvenation. Other side, look at the open pores. Yes, I've treated this patient with a topical retinaldehyde and some topical glycolic acid, but then you can intersperse your safe modality Q-switch laser. So all of these are acquired dermal melanosis, a difficult indication, but we do use, let's come to AN, okay? acanthosis nigricans. This is typical AN. Okay, the patient was not obese. She was not insulin resistant. I checked everything, but she had this. Topical tretinoin, I use it a lot in these cases, 0.025 per second. Alternate cycling with topical GA at night. Laser toning 6 to 8 weekly. And yeah, you can get this. You have to be very patient. The energy, the spot size has to be bang on. Otherwise, you will hypopigment this area. You will get punctate depigmentation, which is a nightmare. And I've had those complications. So this is the other side of the same patient, side, side, side. Okay, under eye, topical retinol thrice a week at night. I use this a lot. Topical Texa thrice a week at night, 1064. Here, under eye area, 6 millimeter spot size. Many, many sessions. I'm not even talking about the sessions here because these are multiple sessions, maybe more than 8 or 10. Again, a little bit of temporal hyperpigmentation. I want you to focus on the forehead. This is the clearance that I achieved. Forehead, forehead. Close up of the forehead. Scars. Work and pigment. Work the most beautiful with picosecond fractional, but you can achieve the result even with nanosecond if you do many, many sessions. So this is it. Let's come to freckles, lentigens. The easiest to treat with 1064, spot size 4 millimeter. Mark your endpoint, mild frosting. Mild frosting. This is all 1064. These are again freckles, as you can see here in this spot, some sort of, this thing, so improvement here. Lot of freckling, lighter skin tone, full face freckled on. 2 treatments. Yeah, she's still undergoing treatment. Tanning, again, you want to treat tanning, very common indication. You use topical lighteners and you do laser toning and lactic acid peel in the same session. These are results with tanning. Come very commonly to us. Rejuvenation, rejuvenation. This is all rejuvenation. I'll skip these slides. All of these came for just, let's talk about scars. How does Q-switched nano, I'm so sorry, work on scars? Fragmentation of melanosomes and accelerated pigment clearance. So one, they work on the macular scars. We understand that it works on the pigmented scars. There is a microphotoacoustic dermal signaling which increases type 3 collagen. So there's subtle remodeling. You cannot compare this with microneedling devices and fractional devices. And there is some skin polishing effect that happens with the decreased sebaceous activity. So if you're using Q-switched nano devices without the fractional mode, this is without the fractional mode, this is superficial pigmented scars only. This, many, many sessions, right? But I was tackling the pigment also, as you can see, and I was tackling this, and the patient was not willing to do too many treatments, so I tried to handle, and this is what I got. Again, some scars. Yeah, this is again not microneedling, just my Q-switched laser toning over here. This patient I already showed you, I will just skip it. Pigmentary demarcation line, a very common indication in our skin. As you can see here in this patient, this is extending from the under eye area to the temple, and this is the result. Again, difficult to treat. These are similar, open pores. Again, good combination with retinols and laser toning works very well. If you're doing your toning correct, you can combine it. These are, I want to talk a little bit about the lip. Only one session, nothing drastic. Nothing drastic really, but I do use a lot on the lip. This I like because I didn't treat him with the scar treatments. I treated him with peels and the Q-switch Nd:YAG lasers. You see the reduction of pigment on the forehead and on the cheeks. Post-inflammatory hyperpigmentation, like this patient, this whole area was acne, active acne and scarring. So you can achieve this lightening with Q-switch. And with that, I thank you very much. If you have any questions, you can please ask me.
We'll do that towards the end, Atula. Thank you very much. So now I invite my friend, Dr. Johannes, who has come all the way from Philippines. He talks about facial dyschromias happening after post-rejuvenation. So managing those dyschromias. Dr. Johannes.
Good afternoon, colleagues. Thank you very much, my friend Anil. I'll be sharing my research on facial dyschromias, especially in brown skin phototypes 4 and 5 among Filipinos. So this is my disclosure. I do not have any conflict of interest in my lecture. So dyschromia is defined as alteration of skin color, either hyperpigmentation, hypopigmentation. We call it mottled pigmentation. It is most common in skin of color and may also involve the skin and the nails. The occurrence is definitely unpredictable. It may be a consequence of photoaging or genetic predisposition, and in most cases, it represents post-inflammatory pigmentary alteration. Facial dyschromias has become a common complaint in the clinics, especially in Southeast Asia, also in the South Asian region. It is a paradoxical form of pigmentary disorder brought about by skin lightening or hypopigmenting agents, lasers, and currently it is being defined by clinical features, histopathology, dermoscopy. It may be cosmetically disfiguring, but in the future, we expect that it will become a complex public health issue. And definitely, I hope you will agree with me that treatment is challenging. So this is basically facial rejuvenation gone wrong with the non-FDA approved rejuvenating sets, which is proliferating in the black market. Peeling solutions, frequent laser toning procedures, especially if this is not supervised by dermatologists. Facial dyschromias is divided into what you already know. So number one is paradoxical dyschromia or exogenous ochronosis from the use of hydroquinone. Just like the other speakers, I am not a very big fan of hydroquinone anymore. And the second one is what we call iatrogenic dyschromia from lasers and skin lightening agents. So exogenous ochronosis, the first case series or seminal paper was from South Africa. So this is actually blackish pigmentation. It is more prominent on the zygomatic malar areas. Due to hydroquinone, sun exposure is definitely implicated. The sites of predilection is similar to photoallergic dermatitis, and it represents accumulation of a substance called homogentisic acid. So you don't only see the black or reddish brown or dark brown plaques or patches, but you also see colloid milia, like pinpoint, papules, and confetti-like depigmentation. Don't forget, if you examine your patients with ochronosis, they have this atrophic scars, which represents like epidermal atrophy. So these are just some cases in the Philippines from the case series that we have done, from the first case series that we have done. Now we are on our second case series, and most of the patients are being followed up throughout the years. This is the dermoscopy. It's very helpful because we see the reddish brown pigments as well as the hypopigmented or depigmented macules. And this is how it looks like in dermoscopy. So it's like starry shaped in some cases. These are the histology. And what we have to understand that homogentisic acid in exogenous ochronosis usually binds to collagen, and the binding is irreversible. There is disruption of collagen cross-linking. There's collagen stiffening, hardening, and collagen degradation. So basically, this is premature photoaging, which is severe. And in very severe cases, we see dermal atrophy or thinning of the dermis, collagen degeneration, pigment deposition, solar elastosis. Very severe pathologic changes, and sometimes we don't know what we should do. Severe solar elastosis, ochronotic pigments, severe collagen degeneration, dilated vessels. So until now, for the treatment of ochronosis, there is no consensus on effective treatments. The reports are limited to just anecdotal or case reports. So there was the last one was a case report treated with a picosecond laser. So combination treatment for exogenous ochronosis in my practice, because most of the cases are being referred to me. So we fragment pigments, and now we understand that they can be fragmented with your Q-switched Nd:YAG laser, very much like a tattoo. Photoprotection, we nourish the dermis because we are dealing with very damaged collagen, cosmeceuticals, injectables. We try to rebuild the collagen so we can do remodeling, dermal remodeling with our ablative fractional lasers. And then we can address abnormality of the vascularity, perhaps with vascular lasers. So this was my patient 10 years ago. So I tried the Q-switch Nd:YAG laser, and I did histology studies. So after 4 sessions, I did a pre and post biopsy. We see active macrophage activity. There's fragmentation of the pigments, even if our colleagues from abroad are saying that the pigments are reddish brown. It can't be fragmented by the, but it can be fragmented by the Q-switch Nd:YAG laser. And when we stain the slides with the CD68, it highlights that the macrophages are actually they're actually eating up the pigment. So this is after 4 months. In most patients, there is very active macrophage activity, especially for the younger ones. And this is CD68 stain after about 6 months. And if we use, for example, the fractional lasers, erbium YAG, CO2 laser, we can expect also dermal remodeling, which is exemplified in the slide on the right. And these are just before and after pictures. You have to be patient with your patients because sometimes they will require like several sessions, more than 10 sessions, combination of lasers, Q-switch Nd:YAG, to fragment the pigments, erbium YAG laser to remodel the dermis, and the vascular lasers to correct the vascular abnormality. So these are just before and after pictures, and now I'm trying to rebuild the collagen with a new laser called 675 nanometer laser by the brand Red Touch. So this is the patient that I have been monitoring for quite some time already, and she's having an improvement. I am just curious whether she will develop post-procedural punctate hypopigmentation. So this is the patient after 6 sessions of the 675 nanometer collagen laser. Treatment of exogenous ochronosis, I think those who are working on skin of color can have a consensus on how we treat exogenous ochronosis in skin phototypes 4, 5, and 6. So on the other hand, facial iatrogenic dyschromia is a complication from prolonged use of skin lightening creams containing hydroquinone topical steroids. The clinical presentation is similar to pigment laser-induced dyschromia. This represents mottled hyperpigmentation on the forehead, nose, and the cheeks. It has many names. So it was called iatrogenic hypopigmentation from cosmetic use of skin bleaching products, iatrogenic hypopigmentation from pharmacological agents, chemical leukoderma, or from physical or toxic agents. However, the pathology from slides that I have reviewed represent epidermal melanocytosis. And this represents proliferation melanocytes. They are atypical in morphology in the basal cell layer. And this phenomenon has been described by Philip Mackey and Bernie Ackerman a few years back. And it is related to a newly described form of pigmentation, usually on the arms, on sun-exposed areas, which is called acquired brachial cutaneous disc dermatosis. And most of these patients also present with mottled pigmentation or dyschromia of the face. And we see the same histology on the arms and on the face. So atypical melanocytic hyperplasia as well as solar elastosis. So there's severe damage, there's vascular proliferation. And if we want to strategize the treatment of this cohort of patients, we try to strengthen collagen. We try to strengthen the collagen, remodel the elastic fibers by laser remodeling, photoprotection, skin lightening agents using alternatives to hydroquinone, kojic acid, azelaic, and biomimetic WNT inhibitors. We attempt to correct the hypopigmentation with tacrolimus, bimatoprost, laser-assisted drug delivery, or the excimer laser based on their mechanism of action. And then we can address the abnormal vascularity with vascular lasers and injectables to nourish the dermis. These are just before and after photos. So no Q-switched Nd:YAG laser for this subset of patients because it will worsen the mottled pigmentation. So we need to remodel the dermis with a very safe laser, no downtime. So I'm using the 675 nanometer laser. And these are just the preliminary results. I'm trying to follow up the patients over the years. And maybe in the next sessions on skin of color, I'll discuss to you updates on this cohort of patients. So with that, thank you very much. I'm sorry I cannot join the Q&A because I need to go to another lecture.
So we can have 1 or 2 questions for Dr. Johns just now then. Anybody wants to ask anything? So how do you feel, how do you think the Q-switch lasers work for ochronosis?
I think it fragments the.
It fragments
Yeah,
the...
initially I was starting with like tattoo removal parameters, but eventually I shifted to laser toning. And by histology, it actually fragments the pigments.
Okay. And do you use the fractional laser also for the epidermal element?
Now I'm using the fractional
CO2?
laser.
Carbon dioxide?
I'm sorry.
Carbon
The
dioxide?
fractional Q switch, and
Fractional
then the
Q-switch.
fractional carbon dioxide and the erbium YAG laser.
Okay. No, for the basic fragmentation also you use the fractional mode of the Q-switch?
I haven't really tried because initially I was thinking that I have to deal with pigments.
Okay, so you are using the conventional Nd:YAG, Q-switched Nd:YAG,
Yes, with
and
the fractional
with the
handpiece.
fractional
With the
handpiece. Okay.
fractional handpiece.
Okay, anybody else wants to get any information? Dr. Johannes, you are going to have the last of him now. He's leaving. You have a flight?
No, I have a lecture
Lecture.
downstairs.
Okay, thank you very much, Dr. Johannes.
Thank you very much.
Thanks. So we move on to the last lecture of the session. We have Dr. Rahul Pillai from India, south of our country. He is also going to conduct a big conference called DASL in India this time, somewhere in October. You are all welcome there. Rahul talks about treatment of melasma in skins of color.
Oh, good afternoon, sir. Good afternoon, everyone. Thank you. How do I go about it? Can you just make it like I can see? No, see the slide, yeah. Yes. Okay. So my name is Dr. Rahul Pillai. I'm a dermatologist from India. I do practice in Dubai too, but predominantly I'm in India. And in this talk, in fact, I will be taking multiple names of different companies and different products, but there is no disclosure of interest. I'm not here for any representing any company. It's just that trying to put the message across, because I always say honestly, like, I mean, I always take an example because I'm a car fan myself. Like, you just say you have a 640 bhp 8-cylinder car, and I won't say that the 911 Carrera GT would match an Audi R8 or something like that. So just because you have the same specs, it need not necessarily deliver the same results. So the same way about products. Some company products are superior. Why is it so? I have no idea. I'm not a biochemist or a pharmacist. But the truth is, we all in practical experience, we feel that. Now, management of LVL, the talk is going to be about management of melasma. Options are available. Comparison alternatives to 4% hydroquinone, because I'm sure that all of us still do agree that that is what works like gold standard, and that's a parameter of comparison, and treatment suggestions. Now, melasma, as we know, is a common acquired skin condition characterized by irregular patches, primarily on the face. It's quite easy to diagnose, more common in women than in men, multifactorial, and it's more commonly seen on darker skin types. And as we know, it's been divided into 3 types. There is epidermal, dermal, and vascular, probably, or the mixed, we can say. So the real cause of melasma is still not understood. We know that it's an inflammatory condition having various pathological features happening. But then why is it happening? Is it just hormone based, or what are the reasons? We still don't know, because in 10 patients, 9 of them may be women, but 1 of them is a male. So sometimes the hormone theory fails over there. So the risk factor, of course, is genetic, family history, pregnancy, hormone therapy, variations, excessive sun exposure, cosmetic application, and darker skin type. Now, the pathophysiology, as you see over here, there is ultraviolet rays affecting the keratinocytes, which is stimulating the plasminogen activators, plasminogen acting, various growth factors, arachidonic acid, fibroblasts, inflammation taking place, and eventually there is increased melanogenesis. So when you look at it, at different levels there is damage or inflammatory cells acting on melanocytes, keratinocytes, basement, fibroblasts, mast cells, endothelial cells. So this is one of the reasons why we are not able to completely control this problem, because we still can only control it, not cure it rather, because it's a recurring condition. I still remember one senior doctor speak about it long ago that, treating a melasma is there's no point treating it aggressively, because the more aggressive you treat, there's a more chance of faster rebound. The question is about mildly pushing it and suppressing it so that it stays suppressed. So aggressive treatments don't work over here, and the plan should be a long-term plan, that you're going to have this patient for, let's say, I mean, I'm sure that all of us do agree that maybe you have been treating a patient, all of a sudden the patient's problem resolves on its own, actually. So maybe you're looking at another 5 to 10 years, and then maybe it'll improve on its own. We don't know. So all depends on individual variations. Now, another main thing why it's more common in darker skin type, as you can see, the darker phototypes have U melanin, because of which they have large scattered size of melanosomes, actually. Entire thickness of the epidermis, there is melanosomes. It's very UV sensitive. And the predominant type, as we know, is U melanin, which is very different from how pheomelanin actually responds. Now, what we have to tackle, as I mentioned, 4 factors over here: vascular, inflammation, hormone, tissue structural damages, etc., etc. It's not just 4 factors, it's multi-factor, but these are 4 predominant factors rather. Now, what are the treatment options in front of us? Okay, the most important thing, cornerstone, would be use a good sunscreen consistently. Anything that inhibits melanogenesis, master stabilization, endothelial, vascular endothelial growth factor suppression, it does help. Keratinocyte-induced plasmin inhibition helps. Lightening creams, antioxidants, peels, low-level vascular lasers, pigment lasers. Whatever said and done, eventually the bottom line is maintenance is essential. Now I'll start with Klinman's formula. It's been considered still the gold standard, and probably all over the world, probably the most used when it comes to melasma. Talking just to put the photograph of Triluma, because they are the original parent brand. That's about it. 1975, Klinman invented this formula. It's been modified. It's been made little more friendlier to the skin, but still, even the Rook's textbooks of dermatology says don't use it above 4 weeks. And we all know that within 4 weeks, melasma is not going to get controlled. So most of the time, the patient and us being dermatologists, we tend to prescribe it for 8 to 12 weeks. But what after? Most of the time, we go on to some skin lightening agents after 12 weeks, and the melasma starts to recur. So it's a never-ending story, actually. The second option, I would say, another good option right now would be use of hydroquinone. Different hydroquinones are there in the market, depending on country to country. In India, we just have Nuderm system. That's the only thing that's available over there. It's not available in Europe. It's available in US. So different countries have got different, way of approval for it. Personally, I feel this Obagi system or Nuderm, again, as I told you, I have nothing to do with them, is working really good just by practical experience, because over here, we are here to understand what works and what doesn't work. Probably that's the reason we are attending this session. So Obagi has got multiple products over here. They order a particular regime, like, cleanse, moist, morning this, morning the night this, exfoliation, moisturizing, etc. I don't know if all that is very important. I do give it because as dermatologists, most of the time the patients ask for a regime which they have to follow. But I would say 4% hydroquinone works, actually. I would like to conclude it over there. It's one of the best quality hydroquinone that's available in the market. Again, the problem is ochronosis. So there's a scare of ochronosis. Can we continue it? How long can we continue it? So after 3 months, let's say we achieve results and we stop it, again, there's a rebound. They keep telling you go to Arbutin, Leucorize, and all that and all. Personally, for the last 2 years, I've been using it. Most of the time, when I change, it comes back. So that problem still persists. So you can see the results, actually. There's quite significantly good results. In fact, fast results, I would say. You would get results by just 3 months, actually. Most of the time, 90 days itself shows significantly good results. So there's something that I would recommend. Azelaic acid, it's not the most powerful of skin lightening agents. The only advantage I see in azelaic acid is melasma sometimes, most of the time, you would say, recurs, in two phases of life. One is during pregnancy, another is when it's nearer to menopause. So it's safe to use in pregnancy and lactation. So when a patient comes to you at that particular point of time, there's nothing much in front of us which we can prescribe. That is the reason I can say we can try azelaic acid. Kojic acid. It's something that has been hyped up. Sometimes I feel it's a little overhyped product. Does it have skin lightening property? Yes, it does. Does it help in melasma? To some extent. Would be the first choice? No, it won't. But then, yes, it can be something which you can use once the pigmentation comes down for maintaining, and you can try that. Ascorbic acid, what I found about vitamin C is, in my opinion, is it's a calmer. It calms the skin. So the patient comes with really irritated skin, not immediately the first day. You first improve the skin tone and you put on vitamin C. Overall, there is skin improvement. So I would say it's mostly like a jack of all trades. Like, you give for under eye pigmentation, you give for acne pigmentation, skin lightening, antioxidant action, melasma, etc. But that is something that can be universally prescribed provided the patient adapts to the vitamin C and there's not much irritation. Tranexamic acid. Topically, I have not found it to be very effective, although there are some studies showing it is, I don't know. My personal experience has not been that great. Injectables, most people do agree that injectables do work. It helps actually. Orally, definitely it does work actually. So 250 milligram given twice daily. I also teach in a couple of medical colleges as visiting professors. So we did a study in my place, Thrissur Medical College, and we gave 500 as stat dose actually. We had a study for, not a long study, 6 months study, was done by a postgraduate actually. So, and it was found to be equally effective. Of course, even the safety profile, we didn't have any complications at least, but still I would stick on to the 250 BD dose, and it does work. Again, the moment you take them off tranexamic acid, you would say that if the vascular component is what is prominent, it keeps recurring back. Now, this another component which I talk about, Dermamelan. It is by a company called Misa Aesthetic. Again, I use that because they have got this patented compound called melaphenone, which only they have. So I don't think anything, just because you mix retinol, ferulic acid, and diosmin, it doesn't give the same result as long as you have melaphenone in it. It definitely does give results. I have been doing a couple of studies with it. It's a slower acting compared to hydroquinone 4%, but overall there is improvement in skin quality. Patients does improve. The advantage I found in this is you can maintain them for longer time without much problems of any kind of ochronosis, irritation, etc. But the only minus point I've seen is there's a bit of peeling which persists even after you follow this method, that sometimes patients find it irritating. So if they have a very sensitive skin, I would say it's not the treatment of choice. But then on long-term safety-wise, yes, it's good. Now, Dermamelan versus hydroquinone, I found them to be giving same kind of results. Only thing, one took 90 days, another took 120 days. Long-term use, yes, Dermamelan is possible. Short-term use, hydroquinone probably is what gives best results. Now, cosmelan is another ingredient of the same company. It has the same patented melaphenone, but the other ingredients are very different. It's got kojic, vitamin C, niacinamide. Now, to be honest with you, Dermamelan costs more, and it is considered probably a little more dermatology prescribed and for melasma specifically. While Cosmelan they don't have such specifications. They say it's more or less for epidermal melasma than for dermal melasma. But in practical experience, I would say Cosmelan does probably better results than Dermamelan. I don't know why, maybe I'm wrong, but my studies or my personal experience of 2 years have shown that Cosmelan is the go-to treatment more than Dermamelan. And more patients are also more probably compliant with this treatment than with Dermamelan. It's got various properties. It does work. In 1 month itself, you do see results, and the long-term maintenance also is easier and less costly compared to the previous compound. So this is something which I do highly recommend. You can see that, we all talk about Korean skin type. We can't get Korean skin type unless we are Koreans ourselves. So that's not there, but then you can say that you do get really fabulous skin by using this product. So this is something which I prefer these days. Even though I do have a Pico, I prefer to use this most of the time because this does the job. So why go for something more expensive? So you can see over here, it's the same patient. I'll say the reason treating these conditions as a doctor is, see, it's not just about treating a particular condition, it's about improving the confidence of the patient. Most of the time, it's a psychological impact they have. It's a 36-year-old woman who comes and saying that, oh, doc, I used to look good before. I used to feel like this before. Now this is affecting me. Everybody keeps asking me. It matters in every way. The way they talk, the way they mingle, the way they socialize, the way they dress, the way they groom. This is where I feel as a dermatologist, we come into the picture because we are not here just about beauty. This aesthetic part is an integral part of life. And the moment we actually stress upon that, Other specialties sometimes make fun of us, saying, oh, cosmetology, you're here to make money. No, we are not here to make money. It's equally important like psychiatry. You need somebody to talk to. You need a psychologist. All of us have problems in life, you know. So same way, aesthetically also, it is very important. There's no point buying a beautiful house and having a fabulous car if you don't feel confident about who you are, you know. So sometimes it matters. Every individual has a different way. Maybe there's another person, it doesn't matter. But many of us, it does matter. So I do feel it is an integral part of our life. Now, comparison, as I didn't want to put the name of the product, so it was compound A, compound B. I found, as I mentioned, the compound A is hydroquinone, still the gold standard, giving the best results. Long-term use, not possible. Compound B, probably, compound B is, let's say, Cosmelan, Dermamelan. Good results, more expensive. Is it worth it? That's up to us, depending on the clientele. Compound C, I can say probably is Cosmelan, gives equally or better results than Dermamelan, lesser expensive, long-term, more safer. This is what I found. What are the other options? I'm running about time. I can just run through for 1 minute. So just 1 minute, yeah. So we can use the yellow peel, acylic, TCA, phenol. All of them do work. This is one company which I've been using for so long, actually. I mean, I'm just put this because I've been using it for 16 years. And this got these ingredients. Does it work? It's basically, it does work. So if you're looking at economical treatment, these ingredients do help, actually. So I always say peel is the best value for money procedure, something which you can give great results and doesn't cost a lot for the patient. Something we can even give a complimentary if it doesn't work. It's not like a laser. So sometimes simple things also works, actually. So I've been getting TCA peels. TCA was the go-to peel, let's say for me 10 years ago. It gives results. Temporarily patient is happy, then it comes back. Again, on a darker skin type, you can't use above 15 to 20%. You have to be careful. There's a lot of post-procedure care also, but it is something which we can. So TCA, I would say, works. Now, a combination of Q-switch and a fractional CO2 is something which I've been doing. This is what I used to do a lot before. I used to have a pico laser. It used to give results. It's never the go-to treatment. But if a patient comes to you saying that I went here, I went there, I did this, I did that, nothing works, I want it removed immediately, yes, an ablation does help. Q-switch also can help actually in suppressing it, but it's never a solution. Q-switch, in my opinion, is probably, you have to be extra careful because the heat produced can actually be a stimulation for further worsening of melasma also. So it's a double-edged sword, which you have to be very careful. It's a fine line that we'll be threading. So we have to explain that, be careful. It's a choice which the doctor has to make with the patient. Now, this is a pico laser. It's not my case, actually. It's by a doctor from Thailand, it's if I'm right. It gives fabulous results. I have attended sessions of Photona and PicoSure and all that, and it does give really good results because pico laser is mainly working on photoacoustic effect, not the photothermal effect. So because of that, it doesn't actually really stimulate the melasma. So if you really want to treat melasma with a laser, I would say probably a pico would be a treatment of choice. But in my mind, what I think is if I'm going to treat like 6 sessions of a pico laser, what I'm going to charge the patient, and it's going to take about 4 to 6 months, is achieved by half the cost with the other treatments that I had mentioned before. And eventually, no matter what you do, it's going to recur back. It's a question of how you are going to maintain it. 6 or 7 out of 10 recurs. So that's a choice, again, which the doctor has to make depending on the patient's needs. So remission of more than 3 years, this patient has been quite happy. So these doctors, when I spoke to over here, they have been very happy with the results, actually. So I would like to finally conclude that, yes, peels is a useful and effective method of maintaining melasma. Creams, yes, do work. Newer preparations like Cosmelan, Dermamelan give really great results, if not superior to hydroquinone, but still hydroquinone is the gold standard. The question is how we are going to use it. Thank you very much.
What picture is that, Rahul?
That's my clinic.
Oh, beautiful.
Thank you.
Okay, so do we have any questions? Okay, Rahul, I wanted to ask you, what was this about? Something that was in my mind. Okay, I'll ask you later. Anybody else? Yeah, please. Can you take the mic?
Comparing with the laser used in melasma between the peeling, how hard or difficult with the patient to tolerate with the consequence of the treatment? Like, in my opinion, peeling is very dryness or something like that in Thailand. And about the laser is it depends on the mechanism of the laser, but it's easier to deal with the complete with the downtime things like that.
But
In Thailand, it's not used so much as peeling in
you
Thailand.
okay? In Thailand, you don't do much peeling. You mean? Yeah.
Yes.
I'm surprised because you all are probably skin type 3 or 4 compared to us Indians. We are 5 or 6 probably. Fitzpatrick. I think you should be doing a lot of peel and nothing to be worried about. If you look at all these kits, there's a protocol. It's not just about the peeling again. There is some compounds for recovering the skin damage. Okay, there are compounds which helps in epidermal strengthening, turnover, healing, etc. So always combine a peel with some protocol post peel, which helps in recovering for the next 10 days. So that is the way I follow. I mean, if you're talking specifically about this particular compound, there is something called melan recovery, which is specifically about recovering the epidermal damage, actually. So I put the patient on this melan recovery twice daily, which is actually more expensive than the sunscreen, actually, what they provide. And a good sunscreen for the 10 days, it actually helps a lot in healing. And then you start the part 2, which is a little more, again, aggressive part, which is mild exfoliation, which is like a home care. So together it does work. But if you're looking at all the yellow peel, TCA peel and all, you again combining it, see the yellow peel in India, I charge something like $60, $50, $60. I can't ask them to buy a $80 post-procedure cream. It doesn't sound good actually. They will not do it. So I used to combine with probably products like epithelial AI, hyaluronic acid gels, simpler products like about $8 to $10, which is very good hydration. In fact, something as simple as a good glycerin or a white soft paraffin, liquid paraffin also helps actually. Used to do a lot of it 16 years ago. Now that, patients want something little more, see when they come for an aesthetic treatment, you write something very simple, they are like, oh, this is not that great, So you write something which is branded, which is much better. But anything that gives good moisturizer, keep it wet for the next few days, will heal it good.
And another one is that the in my vein too.
That's okay. Just
and another one is if another benefit of the peeling is like freckle or pore size, in your opinion, is better?
see, I usually never promote a peel for those two procedures. Freckles, it does help a TCA peel, even peels like, retinol peels and all, does help actually if it's a superficial one. I will never say it's a treatment. So sometimes patients don't want to, because what you see with freckles when you treat with lasers, initially there's worsening and then eventually clearing. So sometimes patients don't want that downtime. So honestly, I don't ever advise a peel for freckles. For pore tightening, to some extent, maybe my favorite go-to peel would be a Sally peel actually, not any of these peels. It does help because all the sebum regulation, everything happens, the blackhead, whiteheads and all gets cleared. So there is some tightening effect. Although I don't promote it actually much for that.
I think different indications have different treatments. Melasma, I think we are going back to the old days. Lasers were in for some time, but now again we are a little skeptical about using lasers. Lasers are the last option again for melasma. But freckle, I think the first indication is a laser. If somebody wants to get rid of freckles really, they have to go, and it's very gratifying. Although it recurs, if the patient is explained that it's going to recur, you have to come back after a few months, you're definitely going to get a few again, they're happy. Because clearance is superb. One session or maximum two and you are totally clear as far as the freckles are concerned. But melasma, you have to be, and I think chemical peels, if done judiciously, I feel what happens is that we do a peel, for example, today with a particular concentration, particular peel, the patient comes back after 2 weeks. We don't, take out time to feel the skin, to understand the quality of the skin at that time. It may be different. If you are careful and you make sure that the skin is in good health, it is moisturized, then you are not going to have much trouble. It usually happens because the skins are different at different times, so they may react, they may get irritation.
Thank you. Because in Thailand, we have to explain more. If we only explain that we treat melasma, patients always ask, when what else or something like that. Thank
You
you.
should try this. You should try this method.
I think
Let's try it
chemical
out.
peels are a very good addition to your topicals. I think lasers should be the last.
Yeah.
You guys use a lot of lasers, but you get away because you have a better skin than ours. We have a lot of rebound hyperpigmentation. I think Atula will agree. Freckles.
And definitely not even a TCA, nothing. Like it just does so beautifully clear if you target it with even 106. So very safe for asking. 2 sessions are just completely
Yeah.
common, and that's just it's about the sun protection. Very
Yes, yes. So do we have any other questions for the 3 speakers that are left here? So all you guys have late flights. Many people are running off, take their flights. Any other question? Okay, then I think it's time to close. Thank you, Rahul. Thank you very much, Atula. We can have one picture before we move on. Come.